So yung may mga questions po, lagay lang po natin sa chat box ang mga questions na. Thank you.
Okay, so let me start with the COVID-19 in children. So many articles have been written about COVID-19 in children. And COVID-19 in children and adolescents account for less than 10% of cases in the Philippines. Since it is a primarily a respiratory disease, it manifests as a flu-like illness with fever and cough as the most common symptoms in children. Most of the cases of COVID-19 in children and adolescents are mild, but some may have severe and critical manifestations, including what we call the MIS-C or the multisystem inflammatory syndrome in children. Children and adolescents with coexisting illnesses or medical comorbidities are believed to be at higher risk for severe COVID-19 disease. To reiterate, children are generally at less risk for severe disease and death, but children with comorbidities are at a higher risk for COVID-19 infection, and those with pre-existing conditions are 1.8 times more likely to have severe COVID-19 infection and or will require intensive care, and 2.8 times more likely to die from COVID-19 infection. As an evidence of children with underlying medical conditions with greater risk of having severe COVID, a systematic review of nearly 9,500 children with comorbidities from January to October of 2020 has shown that there's a higher risk of severe COVID-19 among children with comorbidities than for healthy children. And children with underlying conditions also had a higher risk of COVID-19 associated mortality. Among the pre-existing conditions, obesity was reported to be the most common one in this study, and children who were obese were 2.9 times more likely to have severe COVID-19 infection. When Delta variant started to appear, we gathered some data from tertiary centers in Metro Manila, and this included National Children's Hospital, Philippine Children's Medical Center, Philippine General Hospital, Amang Rodriguez Memorial Medical Hospital, and some regional hospitals. And we were able to gather raw data as to the number of COVID-19 patients, number of COVID-19 patients with comorbidities, number of COVID-19 patients aged 12 to 17 years old with comorbidities, and the number of deaths of children aged 12 to 17 with comorbidities. Obviously, from July to August, there was a jump in terms of the number of cases. And rates of hospitalized adolescents aged 12 to 17 years with comorbidities in these public hospitals ranged from 3.7% to as high as 71%. Fortunately, mortality in this particular subset of population was remarkably low compared to what we know happens in adult population. So just to walk you through to the other hospitals which were involved, Bulacan Medical Center, they contributed some of its data. Region 1 Medical Center, Corazon Locsin Montelibano Memorial Regional Medical Center, Zamboanga Medical Center, Southern Philippines Medical Center, Davao Regional Medical Center, and Region 2 Trauma and Medical Center, which is situated in Nueva Vizcaya. Among the participating DOH hospitals, I think it was Southern Philippines Medical Center who reported the highest number of COVID-19 patients with the highest number of patients aged 12 to 17 years old with comorbidities. So these are some of the underlying medical comorbidities encountered in children who have confirmed COVID-19 as reported by some hospitals. So common among these hospitals are the hema and oncologic diseases, neurologic and developmental diseases, cardiac diseases, and renal diseases. In the latest case bulletin released by the Salvacion Registry, which stands for Surveillance and Analysis of COVID-19 in Children Nationwide, hematologic oncologic diseases, neurologic or developmental illnesses, and gastrointestinal diseases are the top 3 comorbidities reported in the registry. On September 6, 2021, due to equity and vaccine supply issues, the Philippine Pediatric Society has released a statement that the older and more vulnerable age groups remain to be prioritized. Once the country will have adequate vaccine supply and sufficient percentage has been vaccinated in the priority adult groups, children, particularly adolescents, aged 12 years and above with comorbidities, and children who are children of healthcare frontliners may be given precedence for vaccination. As of October 8, 2021, the A2 priority group and the A3 priority group have reached more than 50% of being fully vaccinated. A2 now has 54.36% of being fully vaccinated, while A3 has 78.47% of having been fully vaccinated. On September 30, 2020, the Interagency Task Force for the Management of Emerging Infectious Diseases approved the commencement of the COVID-19 vaccination in the pediatric age group, starting with 12 years of age with comorbidities. This is the approved DOH detailed list of underlying medical comorbidities as proposed by the Philippine Pediatric Society and the Pediatric Infectious Disease Society of the Philippines. This list will be for medical practitioners in considering whether an adolescent aged 12 to 17 years of age can be prioritized for vaccination. So the red highlights are actually the general categories of the different conditions, while the smaller fonts are actually the in specific conditions under each category. I'm sure DOH will give a copy of these to all the participating hospitals and LGUs. Right now, there are 2 COVID-19 vaccines with Philippine FDA emergency use authorization for pediatric administration. These are mRNA-based vaccines, and these are Moderna, approved for age 12 to 17 years old, and the Pfizer-BioNTech approved for use beginning 12 years old and older. The apparent advantage of vaccinating adolescents aged 12 to 17 years old is to protect them from getting COVID. The mRNA, the Pfizer vaccine, is safe based on a short-term safety assessment as reported in a safety and immunogenicity trial involving 1,131 vaccinated children. There is also presence of high-level evidence indicating strong immunogenicity and vaccine efficacy against symptomatic COVID-19 in adolescents. This evidence is based on an ongoing phase 3 trial involving more than 2,000 participants aged 12 years old, and vaccine efficacy against symptomatic COVID-19 from 7 days after the second dose was 100%, with no cases reported among those participants who received the vaccine. Since the presence of variants of concern like the Delta variant has demonstrated increased transmissibility across all age groups and has been associated with greater risk of developing COVID-19 for adolescents, especially those with underlying medical illnesses. Vaccinating the latter may result in reduction of severe COVID-19 infections and possible complications, hospitalization, and even death. Okay, the other benefits of vaccinating children and adolescents, this can reduce disruption to their education by preventing disease and reducing potential transmission and outbreaks in school, reducing disruption to parents and family work, enhancing well-being of adolescents of not being implicated in the spread of virus to others. And this will also encourage the return of regular pediatric care, including vaccination against other vaccine-preventable infectious diseases. In the clinical trial conducted in adolescents, local and systemic adverse events occurred within 7 days following vaccination. In over 90% of participants among 12 to 17 years of age, vaccination local reactions occurred, and the most common of which was pain over the injection site, a mild and transient reaction. Fever as a systemic reaction was more observed after the second dose. There have been reports of myocarditis and pericarditis as having temporal association following immunization with mRNA vaccines. In the United States, where mRNA vaccines have already been given to adolescents, reports of myocarditis or pericarditis occurred within 7 days following the vaccine males, with rates of 4.8 cases per million doses aged 12 to 15 and 5.2 cases per million doses aged 16 to 17 after the first dose, and 42.6 cases per million in the 12 to 15 age group and 71.5 cases per million doses in the 16 to 17 age group after the second dose. Now, this data suggests causal relationship, but the mechanism remains unknown. There are no risk factors identified, but the risk appears in male adolescents aged 16 or older and often occurs after the second dose. Those who had this event quick recovery with supportive care. And more precise data on this vaccine attributable of myocarditis and pericarditis is still being awaited. So, a lot of the people here in the town hall are already experts, okay, in providing vaccination, since I think you were part of the vaccination team during the adult rollout. But let's remember that we are dealing with a different set of population. We're dealing with adolescents who belong to the pediatric age groups. So these are the things to remember by the healthcare workers, particularly who will be part of the vaccination team during the rollout. So these are the minimum requirements to be fulfilled. The recipient must belong to the 12 to 17-year-old age group. that recipient has to have an underlying medical comorbidity, which is included in the DOH list, and there should be a proof of medical certificate with clearance from the attending doctor. Okay, when talking to the parents, please make sure that you give clear and simplified explanation of the consent and assent to both the parent or the guardian and the adolescent. And assigned consent and assent form is essential. Uh, we should have a knowledge on the precautions and contraindications of giving the vaccine. Examples of precaution. There's no contraindication in children who will come in with acute illnesses. But it will be wiser to delay vaccination if you encounter potential recipients who have acute, moderate, or severe illness. Defer vaccination for flu-like symptoms. Advice for a COVID RT-PCR test. Okay, and those who will come into you who have history of food or medication allergy, vaccine can still be given, but please be in the presence of a close or presence of a medical specialist who can recognize and manage allergic reactions. Contraindications, examples of contraindications. When the recipient developed anaphylaxis during the first dose, and when the recipient developed myocarditis or pericarditis after a COVID-19 mRNA vaccine. The fourth is knowledge on the correct route. Okay, the Pfizer vaccine is given intramuscularly at 0.3 ml, and the interval between the first and the second dose is a minimum of 3 weeks. And then appropriate monitoring of adverse events following immunization. Usually, we observe the patients for 15 to 30 minutes. If ever allergic reactions do occur, they usually occur immediately. Kadalasan yan within 15 minutes. And in-place referral system for appropriate medical management in case of a severe adverse reaction. And last but not the least, since some of the hospitals, this will be their first time to have Pfizer vaccine in their facility, there is special handling and storage requirements for the Pfizer vaccine. I guess this is my last slide. Thank you very much.
Maraming salamat po, Dr. Buni. Habang nagsasalita kayo, Doc, marami ng questions. So, dito natin sila sagutin. Thank you, ma'am. To discuss the vaccination process, may I now give to you Dr. Keisha Lorraine Rosario and Bocoli from the Department of Health. Dr. Rosario.
Good afternoon, everyone.
Good afternoon, Doc.
So, good afternoon, everyone. We welcome you all to this town hall, and we thank Dr. Boni for giving the context and the important points why we are doing the pediatric vaccination for 12 to 17 years old with comorbidities. So on our part, we will share to you the vaccination process and the operational side of the vaccination rollout so that you'll be oriented and what are the plans and the guidelines of the Department of Health regarding the vaccination. So as Dr. Buni has lectured kanina, that the IATF provided a resolution, and this is drafted as a resolution number 141, in which the IATF already approved the vaccination rollout to the pediatric population. But then the rollout is only limited to individuals aged 12 to 17 years old, and those with comorbidities. So I saw some of the comments a while ago, no, if we can start vaccinating the pediatric population without comorbidities. As of now, the all expert group has not given their approval and the recommendations to start vaccination for the pediatric population without comorbidities. So the guideline and the vaccination rollout as of now encompasses only the pediatric population ages 12 to 17 years old with comorbidities. So the rollout will be done in a phased manner or in a phased approach as determined by the National Vaccination Operations Center. So here are the general guidelines. We will run down to you the general guidelines and also some of the details on the operation. So for the general guidelines, it says here that we will be rolling out in a phased approach while considering the vaccination coverage of the eligible of all the eligible population or priority groups, no, specifically priority group A2, the senior citizen per region. So the context in which when the vaccination will start in each of the region will depend on the coverage of their A2 vaccination. And that specifically for the fully vaccinated coverage. So as of now, since the National Capital Region has reached 82% coverage for their senior citizens, then they were allowed to be the pilot or the first to were allowed to conduct the first phase of the vaccination rollout. And then as Dr. Buni has informed us that we will be using the EUA, the vaccines with EUA for 12 years old and older, and based on our Philippine FDA, we have two vaccines, no, and these are mRNA vaccines, and that includes Pfizer and Moderna. So for the vaccination process, we still follow the usual vaccination process, and in this includes registration, screening, counseling, reporting, the AFI monitoring, as stipulated in the Department Memorandum 2021-0099, and other relevant policies that were cascaded by the Department of Health. And for the protocols in the management of AFI, ASI, no, they shall follow the provisions in the EUA of the FDA and also succeeding policies from the Department of Health or other policies that been issued by concerned government agencies. So and for those for the storage and handling, we also follow the Philippine FDA EUA. So for the implementing guidelines for the prioritization, as Dr. Bunyi has said to us, no, that the pediatric population aged 12 to 17 years old with comorbidities has the same risk with those individuals with comorbidities. So they will be part in the category of priority group A3, individuals with comorbidities. However, in the reporting for ease in the implementation, they will have a separate entry in our reporting templates, and they will be tagged as pediatric A3. So for the implementation rollout, so we have 4 phases of the implementation rollout. No? So the first phase will be the vaccination rollout in selected hospitals in the National Capital Region. This is the start of their vaccination as determined by the DOH, where the hospital shall vaccinate their patients or cohorts. So as you can see here, we do this phase approach to ensure that we'll get the lessons and to roll out slowly so that if there are changes in implementation, we can tweak for the next phases in the implementation. As Yusek Mirna has mentioned a while ago, we shall do evaluation in after each of the phases so that we can integrate some of the learnings that we will get from each of the implementation, and then we'll integrate it as we expand further the vaccination to other areas and to a larger population. So on the third phase, the second phase will already include other hospitals as identified by other local by the 17 local government units of the National Capital Region. And so they can select at least one. They may choose more than one for the rollout. So it's either an LGU managed hospital or a privately owned hospital. So on the third phase, the hospitals of the national capital region may also expand their vaccination, no, utilizing their other hospitals, and the other regions with more than 50% coverage for their fully vaccinated priority group A2 may also roll out the COVID-19 vaccination for pediatrics. On the fourth phase, no, to ensure that we'll get all the lessons we get from the hospital-based vaccination, then the NVOC will determine when this will be, and if it is really necessary, we will expand it to the regular vaccination site. So this provision is still will depend on the quality and also the learnings we will get from the first, second, and third phase of the implementation. So for the first phase, this is the timelines will be on October 15. Ito po tayo lahat, dito tayo, no? All the hospitals, the 9 hospitals will start on the first phase October 15. The second phase will start at October 22. And then the third phase for the National Capital Region will start by October 29, and then for the other regions will start by November 5. Then the fourth phase will be determined by the NCOC. So now, as you've all known, no, we will start, as mentioned, October 15 for the first phase. We have 9 hospitals already. So these are the National Children's Hospital, Philippine Heart Center, Pasig City Children's Hospital, Fedelmondo Medical Center, Philippine General Hospital, St. Luke's Medical Center, Philippine Children's Medical Center, Makati Medical Center, and Cardinal Santos Medical Center. So you may roll out first to your 15 to 17 years old patients, and then if you have completed the 15 to 17 years old, then you may roll out to your 12 to 14 years old patients. So for your allocation, so we'll be using 2 vaccines. Each will be either Pfizer or Moderna. And for the first phase of the vaccination rollout, which is applicable to you, the hospital vaccination site shall be allocated with the COVID-19 vaccines depending on the list of the vaccine recipients provided by the hospital. So for now, we've received the number of vaccinees that you have determined, and we will provide you for the first phase of vaccination with Pfizer vaccines. So our cold chain and logistics team will closely coordinate with you, with your pharmacists for the delivery. So the delivery will start either tomorrow or on Wednesday. So to give context as well, we'll give you the link to the trainings, the updated trainings on the Pfizer vaccination. No? Since the Pfizer vaccination have the Pfizer EUA has made some changes on their cold chain and logistics, no, requirements. Now you may also review the Pfizer training. We will provide the link to you. So we have videos of this training for the cold chain and logistics, and we also have videos for the vaccine administration, so that you'll be updated on the specific use of Pfizer vaccines. So for the Pfizer vaccines, not to give an information to everyone, we can already store the vaccines in +2 to +8. So you can store your vaccines at +2 to +8 for 31 days. However, we recommend that these may be utilized as soon as possible to avoid temperature excursions or incidents of temperature excursions within the 31 days. So for the pre-registration and scheduling, now we've said this before that master listing is not required. However, you can implement your own registration mechanism for you to determine the logistical requirements that you need, the human resource, as well as the COVID-19 vaccines. So for the first phase of implementation, the selected hospital shall schedule their patients for COVID vaccination, and you may accommodate and schedule vaccination of the eligible pediatric population aged 12 to 17 years old with comorbidities as referred by the City Health Office, and as long as a medical clearance is presented during the vaccination. So the City Health Office may also recommend some of their pediatric population for vaccination. But the main objective is for you to vaccinate your own patients and cohort. If they have additional patients that they want to get vaccinated in your hospitals, this can be accommodated, no? As long as coordination is done through your hospital. And since we also see no that some of the especially patients na or obese no minsan hindi naman sila napapa-check up usually on a regular basis no, and if we see these patients outside of our hospitals in the communities, and if the city health office will recommend the vaccination, then we will facilitate the vaccination. So, and the vaccination site requirements, we require a medical certificate to be given by the attending physician or the pediatrician detailing the comorbidities of the vaccine recipient, and this shall be secured prior to the vaccination schedule and shall be presented in the registration area during the vaccination schedule. So the medical certificate shall provide information of the vaccine recipient's comorbidities and shall indicate that the vaccine recipient can receive the COVID-19 vaccine after thorough assessment and evaluation on the date of certification. So the certification also shall not be used for purposes of taking legal actions against the medical practitioner who issued the medical certificate in case of adverse reactions. And then the LGUs shall ensure that the pediatric population aged 12 to 17 years old with comorbidities have equitable access to a pediatrician in all ages. If possible, those vulnerable populations, especially the poor who or most likely have limited access to health services, shall be provided with immediate assistance and shall be prioritized in the LGU's provision of health services, including acquiring a medical certificate. So, additional requirements are the following. No? So, if the hospital or the LGU has records showing the relationship of the vaccine recipient and the parent or guardian, identification cards of the parents or guardian and the vaccine recipients shall be sufficient to be presented during the vaccination activity. However, if the hospital or the LGU does not have any record showing the relationship of both the vaccine recipient and the parent or guardian, a documentary proof such as a birth certificate of the vaccine recipient or court order of parental authority, if applicable, and the identification cards to verify no, na tama talaga itong si mother is the mother and the vaccine recipient is the vaccine recipient shall be required. So for the vaccination site preparation, we ask that there should be sufficient assistive devices such as wheelchairs, handrails if possible to aid the vaccine recipients since these patients are individuals with comorbidities. And also to consider that during this vaccination rollout, we will require the presence of the vaccine recipient's parent or guardian. So therefore, baka double yung capacity that we need to consider when it comes to the number of individuals in a vaccination site. So for the actual vaccination process, so we utilize the standard operational process. We are requesting the hospitals to follow in the steps in in specifically for now, no, since we are rolling out this and in initial rollout, we follow it step by step. We know that the DOH has already, for the adult vaccination, has already allowed no merging of some of the vaccination process. However, for this rollout to the pediatric vaccination, we want to see also that this will be implemented in a step-by-step manner, so that if there will be a time we need to streamline and integrate, we will know which points we need to integrate and which points we need to take out of the process. So for now, we utilize the standard vaccination process, in which we have a waiting area, we have a registration area, and health education and informed consent area. This is somehow very necessary for the pediatric vaccination, and also the health screening area, then the vaccine administration area, and the post-vaccination monitoring area. So for the waiting area and registration, so the vaccine recipient shall be accompanied by a parent or guardian at the vaccination site. And in the registration, you are asked to, or the vaccine recipient and the parent or guardian is asked to present a medical certificate which is duly signed by the attending physician, and to show the documentary proof showing the relationship as mentioned a while ago. For the health education area, so the vaccination team shall ensure that the vaccine recipient and his or her guardian are informed of the benefits, risks, and possible side effects of the COVID-19 vaccine. The vaccination team may also utilize any applicable digital technology and provide fact sheets to the vaccine recipient, including the parents or guardian, to convey valuable information about the vaccine, the contact details, which is really important, of the referral facilities in case of AFI or ASI, and the necessary information needed to be provided for the vaccine recipient to receive his second dose, including the vaccination schedule. Then, after thorough health education of both, this was required by our legal team na yung health education should be provided not only to the parent or guardian but also to the vaccine recipient. And prior to the vaccine administration, an informed consent shall be given and signed by the parent or the guardian, and then an assent which shall also be given by the vaccine recipient. So for the process, for first, the parent is the one who will give the informed consent, but if the parent is not available, the surviving grandparent can be shall be the appointed parental authority. So he or she shall be the one who will take the place of the parent. And if not po, the oldest brother or sister over 21 years old of age, unless unfit or disqualified, or the court's actual custodian. It's either also that they have a court order of who the guardian, the vaccine recipient is, and then they can provide the informed consent. In case of fondlings, abandoned, neglected, or abused children, as the law provides, the heads of children homes, orphanages, and similar institution duly accredited by the DSWD or its city or municipal counterparts may provide informed consent. So without the signed informed consent of the parent or guardian or any individual authorized to exercise as the substitute parental authority, the vaccine recipient shall be deferred for COVID-19 vaccination unless such documentary requirements are accomplished. So if the vaccine recipient also shall not give his or her assent, he or she shall not be coerced in receiving the COVID-19 vaccines. So on the health screening, so a thorough health screening and assessment shall be conducted by a trained physician. For now, on the first phase of the implementation, we are requesting that for your hospital to assign a pediatrician, no, for us to see how our pediatrician will do the health screening, and if we can get the technique and also the how to do a health screening, particularly to the pediatric vaccination. We will adopt and also train our other health professionals for them to be acquainted of how the health screening will be done, and will cascade how it will be done. Then we can utilize a regular vaccination team na health screener. It's either be our friends or our trained nurses who can do it. But for the initial rollout, we are requesting that a pediatrician, no, this is also a request by the all expert groups, so that we can ensure the safety and of the vaccine recipients during the vaccination. So a thorough assessment shall be conducted by the physician at the vaccination site to ensure that the vaccine recipient is clinically well, and also those who have been cleared by the physician in the health screening area shall proceed to the vaccine administration area. So kung kahit may medical certificate siya, but then the health screener will say that for now he is not eligible to get vaccinated, then the judgment of the health screener will supersede the presence of the medical certificate. So the deferred vaccine recipient shall be provided with sufficient information when they are eligible to receive the COVID-19 vaccines. So for the vaccine administration area, no, the vaccinator shall check for the following: the presence of the signed informed consent and assent form, as well as also the cleared health screening form done by the health screener. So for the dosage, we utilize the dosage as stipulated in the EUA by the Philippine FDA for 12 to 17 years old. As stipulated in the EUA, no, we will use the adult dosage for Pfizer vaccines as well as for the Moderna. So there are no weight requirements for the COVID-19 vaccination for the vaccination of the 12 to 17 years old. And then the parent must be physically present during the vaccine administration, and the vaccinator shall inform the vaccine recipient and the parent of the vaccine brand, the dose required, and the possible adverse effects following immunization. So another also operational strategy that we are implementing is that if a parent or guardian or household member are not yet vaccinated, no, while the pediatric vaccine recipient is being vaccinated, they may also get vaccinated in the vaccination site, or they may be scheduled and referred to the LGU and shall be scheduled for vaccination. However, to ensure safety and for the to ensure that someone will be looking after the vaccine recipient after his vaccination or her vaccination, a household member shall always be available to assist the vaccine recipient. So in the post-vaccination, we still follow the time interval required to monitor our vaccine recipient. So 15 minutes if the vaccine recipient does not have any known allergies or history of anaphylaxis, and for 30 minutes if with known allergies or an history of anaphylaxis. On the reporting, we will be calling also your data managers of your hospitals later on, maybe tomorrow on Wednesday, but there are just some certain points na that we need also to consider for the reporting. So, as mentioned kanina, the report will be that the pediatric population aged 12 to 17 years old with comorbidities will be reported as pediatric A3. For the vaccination sites participating in the first phase of the vaccination rollout, you shall submit daily the accomplishment in the vaccination operations reporting system. You will be oriented on this on Thursday. Your data manager will be oriented on this Thursday on a daily basis, and shall submit the vaccination information details, the vaccine administration system as a line list to the VAS uploader Recording in progress. 24 hours later. And as mentioned, no, if the local governments will start rolling out, also they utilize the same platforms for submission. On the line list, there will be some changes in the line list. No, for the usual line list that we have for the adult population, we do not require this, so this will be the additional. So on the line list fields, we have coordinated with the ICT. They will be incorporating another field to record the comorbidities of the vaccine recipient as stipulated in the medical certificate. So that will be free text lang, i-encode lang yung diagnosis ng doctor doon sa medical certificate. And also to ensure that our data system will also catch the name of the parent or guardian who provided the informed consent, they will also pick up the name of the parent or guardian in the recording. So we are showing you the template for the informed consent and assent. Some of the detailed parts are being just cleared by our legal team. Now we are just waiting for their legal clearance. But then this is the template now, no? And as you can see, there will be 2 pages. The first item will be the informed consent that will be given by the parent or guardian. And then on the other side will be the assent, no, in which the vaccine recipient will give his name and also will sign and indicate the date. And here is also a template of our medical certificate. You can already use the medical certificate, and in which you'll have the date, the name of the patient, the age, no, the address, and the diagnosis. And we are requesting that you tick also the boxes here, no, that it says I have thoroughly examined the risk and benefits of explaining the risk and benefits of the COVID-19 vaccination. And then based on the evaluation done on the date of certification, the patient can receive the COVID-19 vaccine. And then it also says here that the parent or guardian is also aware that the vaccine recipient will be subjected to health screening in the vaccination site. And then based on the re-evaluation, they may be deferred or will push through with the vaccination. So then we indicate our name and then our PRC number. So with also this template, now we put here the DOH logo, but then Yusek Kabotay also said that you can incorporate the hospital logo if you want. And for the health screening, I believe our policy team is just clearing the health screening form through the PPS. Now they're saying that the PPS will just clear the health screening form, but then usually there are just slight changes in health screening. So there will be 2 templates also of the health screening. It will be the health screening for Pfizer and also the health screening for Moderna. There are just a little tweaking, but then the process will most likely be the same for the adult population. So for our timelines, no, everyone will start on Friday. There will be just symbolic launching on Friday. We have simulation exercises that will be conducted on Wednesday. And then on Thursday, our CHDMM will visit your vaccination sites and see if we are all ready for the vaccination. Now, for the initial rollout, you can start small. No, you can start at around 50 patients or such. Now, if you don't want to fully launch the vaccination and the next succeeding days, you can ramp up your vaccination. We do not necessarily push for like big numbers of vaccine just in a regular vaccination site. What we want is that you can see the process, how it be conducted effectively, how can it be done for us to replicate in also on the other vaccination sites. So for the link for the Pfizer training, Sarah will share it to you. Hindi pala nakasama sa slides. No, we will share the link to the Pfizer training. So it already includes your videos, your presentations, and as well as the materials for the Pfizer training. So we will just give it a supplemental material for you to get acquainted. So this ends my presentation for this afternoon. Thank you very much.
So again po, we are tasked to deliver in the next 15 minutes the adverse events following immunization of COVID-19 vaccines with special focus on the adolescent population. So the intended recipient for this presentation today is for our vaccination sites. Next slide. So generally, there would be very minor changes in the AEFI surveillance and response if we implement in the adolescent population. What we want to emphasize are as follows. What are the typical reactogenic reactions and how do we manage them? What are the specific adverse events of the vaccines to be administered, particularly on anaphylaxis, myocarditis, and pericarditis, and what needs to be improved by the vaccination sites and our local vaccination operation centers from recurring observations to ensure a responsive healthcare system and sensitive and specific safety monitoring. Next slide. So as a 101, AEFIs are adverse events following immunization, but simply put, they are any event following immunization. They can be a sign, symptom, laboratory finding, or diagnosis. Temporal association alone does not mean causation. That is why we should avoid writing AEFI or vaccine-related reaction as part of your diagnosis or death certificate. It is more of a tag. Next slide. So the most frequently reported AEFIs are listed on screen based on the FDA emergency use authorization. So what we see here are the similar as to how clinical and safety monitoring has been seen in the pediatric population in the other countries that have started adolescent population vaccination. So the first days after vaccination, typical reactogenic reactions are seen, and the difference only in terms of management would be on the dosages of medicines or formulation, especially if the patient or the vaccine recipient may not tolerate tablets or capsules. Next slide. So a common question that has been asked even among adult immunization is how do we differentiate reactogenicity or COVID-19? So some of the side effects of the vaccine are similar to the symptoms of COVID-19, such as fever, chills, headache, body aches, and joint pains, but the vaccine will not cause or give you COVID-19. So the symptoms such as a sore throat, runny nose or cough, loss of taste or smell are not the side effects of the vaccine, while they may be reported after vaccination. So these would better be attributed to COVID-19 infections. So if we see these more upper respiratory symptoms, then we would be lean more on ruling in COVID-19 infection. Next slide. What are the common treatment of common reactions, not just allergic reactions, common reactions? So for the reactogenic reactions, so what we have been most familiar with, this is usually through supportive care, from paracetamol, NSAIDs, cold compress. For mild allergic reactions, it would be through antihistamines, anaphylaxis through epinephrine, while for other types of vaccine hypersensitivity, it would be through oral or intravenous steroids. So our friends from the Philippine Society of Allergology and Immunology have provided a good position statement stating and expounding on these. So we have uploaded these in our bit.ly link, our Google Drive in bit.ly/AEFIC190H. Next slide. So how about the misconception that they would have to take some prophylaxis prior to vaccination to reduce the adverse events or to prevent anaphylaxis? So currently, there is no such data, and it may mask the early signs and symptoms of anaphylaxis, which would delay the administration of epinephrine. Next slide. So based on these and the common adverse events that may be experienced, especially during the immediate post-vaccination monitoring period, the following are the components of the AFI. So we divided this into two. First would be on the diagnosis and post-vaccination monitoring, which would include the medical devices and miscellaneous items. So these include blood pressure apparatus, either a digital or analog sphygmomanometer. But now we should have appropriate cuff size for the respective age groups to be vaccinated. Stethoscope, pulse oximeter, thermometer, also having a pen light, tongue depressor for any serious cases that may need these. For example, if the patient faints or has loss of consciousness, or there may be seizures or any other event that may compromise the airway, or even just to look at the oral cavity. So the case investigation form, a pen and paper, and the list of contact persons and information for referral. So for the management and emergent treatment of AFI post-vaccination, we have listed down a number of items, but basically what we would like to see are those that would be addressing reactogenicity, addressing allergic reactions. We have also provided, since we are administering for the vaccination groups, population groups that have comorbidities, of which some of them have epilepsy or may experience seizures, we have also provided in the list muscle relaxants or sedatives such as diazepam. Next slide. Now we go on to our rundown of some key immunization adverse events following immunization that all vaccination sites and even our local vaccination operation centers should be very well aware of. First would be on anaphylaxis. So anaphylaxis is an acute multi-system allergic reaction to a substance. It is very rare, occurs about 1 to 10 in a million, and typically unexpected to the general population, and can be fatal if not dealt with adequately. Next slide. So the DOH has provided a fact sheet for implementers for COVID-19 immunization, a vaccination program. We have noted that in literature, even not across the COVID-19 vaccines, but generally, associated factors that increase the likelihood of anaphylaxis are previous allergic reactions or atopy. So that is why we have a prolonged on-site monitoring for those who have experience of history of asthma or allergies, wherein we would like to observe for 30 minutes post-vaccination. Next slide. Again, we would like everyone to have a copy of this interim AFI management pathways, as this would be a good blue book to look at in terms of diagnosing and managing any adverse event following immunization, especially those that have that will be immediately treatable or immediately referred. Next slide. So again, anaphylaxis is very rare but fatal. It may still occur after the vaccine recipient leaves the vaccination site or within 24 hours. And given the sensitive population, we should ensure that post-vaccination monitoring is truly followed. So to ensure that this happens, we have to give our guardians and our vaccine recipients hotlines or emergency numbers, consultation or assistance, advise them of what to suspect if they have what to look out for if we are suspecting anaphylaxis or a severe allergic reaction. So it is not just a difficulty of breathing or wheezing, nor also of skin rashes. So it may also manifest initially with lightheadedness or even with abdominal pain. So we'll discuss this in a little while. Also, for any vaccine recipient, we have to provide them the right information that hospitalization is not free for all. AFI or not free for all Filipinos right now. While we strive to improve financial risk protection, similar to any hospitalization, it will depend on the diagnosis and associated case rates from the Philippine Health Insurance Corporation, from what is available from the public or private hospital they are in, the type of accommodation they have, the length of hospitalization, and whether they have other associated diagnoses. So for these, we have to be knowledgeable of what other kinds of medical financial assistance that will be provided, such as the Malasakit program, or the social welfare assistance from the local government units or the Department of Social and Welfare and Development, Social Welfare and Development. So we have to clarify that the PhilHealth Vaccine Injury Compensation Program is only for those serious adverse effects. So when we mean effect, it has been assessed upon causality assessment to be classified as a vaccine product related reaction or a vaccine quality defect reaction. So for this, PhilHealth circular would be more in its place to provide correct information regarding this vaccine injury compensation package. Next slide. So for the clinical diagnosis and management, we have provided this issuances and but the key message here is epinephrine is a must to be accessible at all times during vaccination runs and even across all health facilities, as we have noted that there are some near-miss events that wherein anaphylaxis may not have been appropriately diagnosed nor managed when the patient went to their rural health units, outpatient clinics, or even in hospitals. So a demonstration video coming from the PSAAI has been uploaded to the link in the on screen. Next slide. So the next slides would be a brief rundown lang po regarding anaphylaxis. So for the adolescent population, it will still be 0.5 ml, and we would like to emphasize where to inject it, not at the arm, not intravenously, but anterolateral aspect, the middle third of the thigh. Next slide. So in the interim EFI management pathways from the Department of Health, there is a corresponding table and algorithms on how to diagnose and how to treat anaphylaxis. So next slide. So anaphylaxis is highly likely when any of the following presents. It's either number one, an acute onset of an illness with simultaneous involvement of the skin or mucosal tissue with at least one of the following symptoms in the three systems of respiratory, circulatory, and gastrointestinal, or even just with acute onset of hypotension, low blood pressure, or bronchospasm, or laryngeal involvement, even in the absence of typical skin involvement. So while this is very rare, we have to master this diagnostic considerations, considering that anaphylaxis is clinical. It may be fatal, but with the appropriate diagnosis and treatment, these could be immediately preventable, and we could bring back the patient to his or her pre-morbid state. Next slide. So this just outlines that once you detect anaphylaxis, you put the patient in reclining position with the legs up and administer epinephrine. Again, 0.5 ml per dose intramuscularly only on the mid-outer thigh, even through clothing. And afterwards, we could provide further interventions. So I will not detail on this algorithm, as this is best to be provided to you to read, and also to print it out, place it on your vaccination sites, place it on your emergency rooms, emergency departments, outpatient clinics, wherever patients will be initially seen. Next slide. So even if it starts with an allergic skin reaction, you would have to rule out anaphylaxis. So even if it only starts with pruritus or even rashes, you would still monitor them and do not dismiss these symptoms, as this may be the first sign of progression towards anaphylaxis. Next slide. So aside from this, we also would like to recommend the use of these PSAI infographics and algorithm, so that this could be immediately seen by our vaccination sites, our healthcare providers in all areas. Next slide. Now, if there are any further difficulties in diagnosing anaphylaxis, especially for those that are seemingly looking like anaphylaxis but do not fit the classical picture, we also provide what is being used in terms of surveillance the Brighton collaboration case definition of anaphylaxis. So I will not delve on these in detail, but basically this document outlines what are the specific symptoms, what are the definition of each symptom, and what are the combinations of the symptoms or the major and minor criteria to say that the anaphylaxis should be suspected, or the level of certainty of anaphylaxis from level 1 to 3. So next slide. So this document outlines the major criteria, minor criteria across various organ systems from the skin, respiratory, cardiac, GI, and laboratory findings. So next slide. So level 1 would be one major criteria on the skin plus one major criteria either of respiratory and cardiac. Next slide. For level 2, we would, if there is no major criteria for respiratory or cardiac, this major criteria from the skin should be accompanied by at least one minor criteria from respiratory or the cardiac systems. Next slide. So if there is no skin manifestation, anaphylaxis with a certainty of level 2 would still be diagnosed even with two symptoms or signs. One coming from the respiratory systems, and one from the cardiac system. Next slide. So if there's just one major criteria that fits, so for example, for respiratory, so this should be accompanied by one minor criteria from the other systems. Next slide. Similarly, for cardiac, if there's only one major, then this could be accompanied by one minor criteria from the other systems. Next slide. Now, for level 3, this is the lowest level of certainty of anaphylaxis, but still may be considered for confirmation. So, for level 3, it would involve one minor criteria of respiratory system, but also two minor symptoms or signs from two different systems. Next slide. Similarly, for the cardiac, it should have one minor criteria from the cardiac and two minor symptoms or signs from the two different systems. So we also provide here another way to diagnose anaphylaxis coming from the World Allergy Organization. So these information all are under the bit.ly/AEFIC19PH Google Drive. Next slide. So our key messages for anaphylaxis are as follows. Vaccination sites should convene and disseminate this information and ensure immediate knowledge improvement in diagnosis and management. Print out these materials. Well, for the local vaccination operation centers, we hope that you all coordinate with your respective health facilities and healthcare providers, whether government or whether non-government, whether hospital-based or even in clinics, so that this would be managed and they could easily recognize anaphylaxis. Next slide. Now for myocarditis and pericarditis, so what are these reactions? No? So especially that these have manifested in the late month of the second quarter of 2021. So myocarditis is an inflammation of the heart muscle, and pericarditis is an inflammation of the outer lining. In both cases, the body's immune system causes inflammation in response to an infection or some other trigger. So myocarditis and pericarditis are actually entities that exist even prior to COVID-19 vaccination. So these syndromes or diseases are noted to be seen after viral infection. Next slide. Now, for COVID-19 vaccine, or Muni has noted and presented earlier, it is still very rare and may actually be difficult to recognize. What we know is that it is usually on after the second dose. It manifests especially in male adolescents and young adults. So we have to ensure that our vaccine recipients are properly guided about these. So similar as to our advice take-home prerequisites for anaphylaxis, we have to have hotline numbers, emergency numbers. This advise them of the signs and symptoms of myocarditis and pericarditis, such as chest pain. So usually it's actually chest pain that has been observed in the CDC, VACers, or even in case studies, case reports, and case series. Also, some of them experience breathlessness or even palpitations or a forceful heartbeat that may also be irregular. So similarly in anaphylaxis or any vaccine recipient, we have to explain them of what is covered only in terms of hospitalization and what the PhilHealth vaccine injury compensation package really needs. Next slide. So in diagnosing and treating myocarditis and pericarditis, so CDC is still working on their definition, but we have provided these in the next slides based also on the Brighton collaboration case. To prepare your vaccination sites, if you want to learn further, you could also watch the WHO webinar. It's around an hour webinar regarding myocarditis and pericarditis. But basically, next slide. So in the working case definition for myocarditis and pericarditis are as follows. So it would be both clinical and diagnostic examination. So at least one new or worsening symptom of chest pain, dyspnea, palpitations or syncope, and one new finding from the following: elevated troponin, abnormal ECG, abnormal cardiac function or wall motion abnormalities in 3D echo, and cardiac MRI findings. While also noting that we have to have ruled out other identifiable causes of symptoms and findings. So it seems that myocarditis could actually look like acute coronary syndrome and myocardial infarction. So for the confirmed case, this is actually more difficult. That is why even in the US, they also consider just even having a probable case of myocarditis because it would need a histopathologic confirmation or a elevated troponin and a cardiac MRI. So for pericarditis, it would be similar, but we, as noted in our slide, what is different in pericarditis would be presence of at least two new or worsening the following clinical symptoms, particularly on acute chest pain, and even the type of pain, since it will be made worse by lying down, by deep inspiration, because it is an inflammation of the lining of the pericardium. So, what would increase the pain would be these kinds of activities. Likewise, on physical examination, we would see pericarditis rub and new ST elevation or PR depression on ECG or new or worsening pericardial effusion and echocardiogram or MRI. But what is seen after our mRNA vaccines in the other countries would mostly be myocarditis. But we should also look at these pericarditis as these may also occur. Next slide. So we have also provided these in a algorithm format coming from the Brighton collaboration. We will not delve on these. It will be really quite similar as to the previous slide from the US CDC. Next slide. So this would be on pericarditis. Next slide. So should we be worried? So this has been already discussed by Dr. Buni, but we would like to reiterate. So from the 323 reports in the VACers, or the Vaccine Adverse Event Reporting System of the United States of America, they have noted that the median interval from vaccination symptom onset is around 2 days, with 92% having it appearing within the 7 days of vaccination. And while 96% were hospitalized, most were discharged with a resolution of symptoms. With such resolution of symptoms being managed through conservatively, such as receipt of non-steroidal anti-inflammatory drugs. Likewise, in the compilation of 6 published case series composed of 55 cases by in a review in the journal Circulation, patients presented with chest pain usually 2 to 3 days after a second dose. Some presented with fever and myalgia 1 day after vaccination. they had some abnormalities in certain cardiac related diagnostics. But almost all patients had resolution of symptoms and signs and improvement in diagnostic markers and imaging with or without treatment. Next slide. So what would be the implications of these? As these are more common in the second dose in younger age groups and among males, actually other countries advise that, for example, Singapore, for adolescents and those of younger age, they avoid strenuous physical activity for 2 weeks after any dose of the mRNA COVID vaccines. But again, this is a self-limited with management largely supportive. So we use symptoms to screen, but to elevate the certainty of diagnosis, diagnostic tests have to be performed. Now, on a population level, let us see how the US CDC Advisory Committee on Immunization Practices evaluated the risks and benefits on a population level. Next slide. So we see here visually that they have noted on the right, with the red marks, the number of cases of myocarditis per age group. While it is mostly seen at the younger age groups, if we contrast it with the benefits of COVID-associated hospitalizations prevented for every million doses of mRNA vaccine, the benefits are overwhelming compared to the risk. Next slide. If we provide the numerical calculations, so for males and females 12 to 17 years of age, for every 1 million second dose vaccinations over 120 days, 8,500 COVID cases are prevented among females, 5,700 COVID cases are prevented among males. Among males, 215 hospitalizations are prevented, 71 ICU admissions are prevented, 2 deaths are prevented. Only 56 to 69 myocarditis cases are, and these cases are overwhelmingly usually self-limiting as earlier stated. Next slide. So additional benefits to prevent post-COVID conditions. This would prevent multi-inflammatory systemic reaction for children and prevention of prolonged symptoms or the post-COVID syndromes or long COVID and protection against variants. So the benefits still outweigh the risk in this phenomenon. Very rare phenomenon. Next slide. How about those with cardiac conditions? So we check how other countries screened or whether they saw if there is any evidence yet on those having cardiac conditions developing myocarditis or pericarditis after vaccination. So as of now, based on the guidance from the Australian government, we're in their cardiac society and even their Australian counterpart of their NITAG, do not find any current data that suggests such risk. However, they just advise provided precautions that for those with recent, within the past 6 months or current inflammatory cardiac illnesses, pericarditis and myocarditis, acute rheumatic fever or acute rheumatic heart disease and acute compensated heart failure, they should be properly guided. And there is no current evidence that patients with heart disease are at increased risk of developing myocarditis or pericarditis after a dose of an mRNA COVID vaccine. So that is coming from the Australian government. Next slide. Now we look at the last set of reactions that are more common on adolescents in general and not actually due to the COVID-19 vaccines. So in the past, in the vaccination programs among children, especially adolescents, we see a rise on immunization stress-related response. So this may range from a mild feelings of worry and butterflies to actually symptoms of sympathetic nervous system stimulation. It increases the heart rate, palpitations, difficulty in breathing. So if you are able to hear some stories about multiple number of adolescents, teenagers who faint during vaccination or after vaccination, then these are clusters of those immunization stress-related reactions. Next slide. So how to prevent it? So we have to, for those who have a history of vasovagal reactions or risk factors, They should be immunized in a seated or supine position and only move to sitting or standing if there have no signs of vasovagal reaction. So ideally, the individual should stay seated for 15 to 30 minutes following the procedure, and the healthcare provider should monitor them for signs of vasovagal reaction. Next slide. So usually it's again at some of the adolescents, those with a history of syncope, previous negative experience, with those who have already expressed fear of injections, needles, or even those who have anxiety or developmental disorders. So these are sudden, first before, during, or shortly after immunization. And by the manifestations of these, we should not immediately dismiss that these are just anxiety-related reactions, because these manifestations actually mimic. So again, take home prerequisites, hotline number, emergency numbers. Next slide. And anaphylaxis should be considered as a possible diagnosis. So the first prompt management should be place the patient in a supine position, and if the symptoms resolve spontaneously without the need for medication, then this is immunization stress-related reaction. But this is again a diagnosis exclusion, as we do not want to dismiss them, and we do not want to avoid managing anaphylaxis. Next slide. So if we are want to delineate the symptomology of anaphylaxis versus immunization stress-related reactions, and ISRR, so generally those with anaphylaxis have other symptoms. No? So from the GI or even the skin, especially at the skin, for its attraction to be pales when people plan for the skin for anaphylaxis, they would have rashes, angioedema, and other manifestations. Likewise, for respiratory, if we use our stethoscope, be able to hear some wheezes, stridor. But for those with acute stress response, these usually are here, but they are hyperventilating. So there are other items here for your review. We hope that you also print this out so that we could also learn from each other. Next slide. So we go to the last part of this presentation. So are there changes in AFI reporting? So technically there is none. AFI is not a diagnosis. AFI is any event that may occur within 1 year after the latest dose of COVID-19 vaccine under emergency use authorization. Clinical management is a cornerstone. All AFIs may be reported, but what is essential is to be constantly updated on reporting flow with your LVOX and RVOX. For hospitalizations, death, and diagnosis that you suspect are serious, confer with your respective RES immediately. Combat hesitancy, meet at the BOD through interpersonal communication and counseling. Next slide. So we shall upload this messaging. We shall upload this in the bit.ly link, bit.ly/AEFIC190. So just to reiterate, this is the flow of the reporting. So from our healthcare providers, those who are not situated in the hospitals, please submit it to your local government units. Those situated in hospitals, please submit it to your hospital emergency and surveillance units, and these units will be the one to submit it upwards towards the national level, and the decision to investigate and conduct causality assessment will not be part of the scope of this orientation. Next slide. So aside from reporting, we would like to reiterate that vaccination doesn't end with providing the vaccine to the recipient, nor even after post-vaccination monitoring. So what are the responsibilities? So the vaccination site should really ensure that the vaccine recipient knows what the common AEFIs are, what to do, where to report, where to get consultation, where to seek support if they have experienced something that they have need further support. And also for our local vaccine operation centers, it is not just about the vaccination sites that you would have to look at. Please also look at, confer with, coordinate with all the healthcare providers in your area of jurisdiction, whether government or non-government. Next slide. So we also expanded the case investigation form. So it is simply the same form, but we expanded questions so that this would be utilized better for vaccine safety surveillance, as we have seen in the past 7 months that our investigators, the rescue and those who level, go back and forth with the hospitals, with the healthcare providers for details that have not been inputted as early as the time of reporting. So for the non-serious cases, it will say that only the first page will be submitted. And for the serious cases, we shall modify this presentation, but no, we will not ask that page 1 be initially submitted to notify the SU. We would like to have the complete case submitted in 4 hours after being confident with the diagnosis and with all the feasible workups done, and or the day of discharge if the patient is hospitalized. So we'll before we upload this, we'll modify this slide. No, we will not want that page 1 initially submitted. We would want all the pages, page 1 to 5, submitted as is. Next slide. So again, what to report any event. Which events are recommended to report? Events where the healthcare provider cannot rule out from your clinical assessment that the vaccine may have caused it. Events where the health provider can rule this out, but the patient or relative are still asserting that this is due to the vaccine. And lastly, events where the patient or relative expressed to file claims from the vaccine injury compensation program. And who should report and to whom should they report? Again, for hospital-based providers, to your hospital SU, and for those at non-hospital facilities, to your local government unit, or the local epidemiology and surveillance. Next slide. Okay, so this was just a reiteration of the previous slide. So we would like to emphasize on certain processes. To prevent adverse events, you need to have proper screening. So we have experienced in the past that those who have COVID-19, acute gastroenteritis, and controlled asthma have not been referred, and their adverse events being confused with those due to the vaccine, even if they had this illnesses prior. And also that causality assessment is not a basis for second dose. No? So there is no guideline locally, nationwide, worldwide that states that causality assessment, which assesses whether the vaccine caused the event, is used for clinical immunization decision support system. So for the second dose after adverse events, it would still be the shared decision making between the recipient and the healthcare provider, conducting individual risk-benefit analysis and looking at our clinical practice guidance or position statements. Next slide. So to respond to AFIs, especially those that may happen on site, we would like to reiterate anaphylaxis. So from our vaccination sites to our healthcare providers to our local vaccination operation center, please make sure that everyone knows how to diagnose anaphylaxis or even suspect it, and to treat it with 0.5 ml epinephrine at anterolateral. Next slide. To encode vaccine details, we have seen absent batch or lot numbers in vaccination cards, in the VIMS vax. This result in low sensitivity to rule out vaccine quality defects. So please use the official templates for the vaccination cards, and take note that if you are not wary of this section of our Vaccination Program Act, while we are all immune from suit and liability as emergency response stakeholders, this immunity stops when there is gross negligence or misconduct. So if we are able to see any vaccine quality defects and we are not able to properly see on certain patients because we didn't have any batch or lot numbers, so this may impact your immunity. To report and investigation quality, we see poor quality reports absent clinical details. We would like our local vaccine operation centers to engage all our healthcare providers, especially those who are not serving at the vaccine. since they would be the ones to see the adverse events that could lead into hospitalization or disability. Next slide. I think the last slide na ito, no? So, again po, we would like our hotlines to be functional. We see and hear complaints from patients being turfed or not being seen. And it seems that there was some notion that after giving the vaccine, patients or vaccination recipients do not get the support after when they experience adverse events. No? So we also see that even if the patients have been provided their vaccination cards, they were not properly counseled on where to go, how to manage their own adverse events. So we would again emphasize this and the scope of support from the government. We would like to seek your assistance in clarifying this to our general population, to the vaccination recipients, and even to your members of the vaccination sites. Next slide. So if you want to learn more about the AFIs, we have provided a number of policies, webinars, videos, readings. So it is about pharmacovigilance, it's about vaccine safety surveillance, which is quite a young field nationwide and even worldwide. So to those who would like to read more, learn more, and expand their knowledge towards the fringes of science, please visit bit.ly/AFIC19PH, where we will also provide this presentation. Next slide. So I guess that's it, and thank you for listening.
Thank you very much, Dr. Burdongan. Maraming salamat po sa inyong presentation. Sa mga nakikinig, kasamahan po natin dito sa town hall na to, we will be sending the presentations through your email. So, ang mahalaga po ay nakapag-sign kayo sa attendance sheet. Kasi yung unang line po doon, I think is your, kailangan namin yung email nyo. So, don't send anymore your emails dito sa ating chat box. Checkin na lang po natin kung nakapag-sign up kayo sa ating attendance sheet. The next topic will be the health promotion. The health
must knows that we need to communicate to our patients and parents. Why do we need to vaccinate children and adolescents aged 12 to 17? Children and adolescents can still be infected with COVID-19, can get sick and hospitalized for it, and can spread it to others. And secondly, we need to protect both adults and children with comorbidities who are more vulnerable to severe COVID-19 and death. That still follows our existing prioritization. And which vaccines will be used? Are they safe and effective? So at present, Pfizer and Moderna have been granted EUA specific for children aged 12 to 17 years old. And only vaccines assured of safety and efficacy by the FDA's EUA for this age group will be used for our pediatric vaccination. What are the common side effects? So yan, tatanungin talaga sa atin yan. So marami na pong nabanggit kanina. Our symptoms may be expected similar to adult vaccination of COVID and other vaccines. These can include fever, headache, and other flu-like symptoms, pain, swelling, or redness in the injection site. And these resolve after a few days. But also there are reports of serious AEFIs, such as inflammation of the heart muscle and gallbladder. And these have been reported in studies, but they occur rarely and are a small proportion of the total doses administered. So what benefits do I get as an adolescent who will get vaccinated? And how do these benefits outweigh the risks? So vaccinating those aged 12 to 17 will, number one, protect our children from hospitalization and death, to allow safer face-to-face classes. And three, it can make family visits safer. Also, getting vaccinated protects our family members who are not yet eligible for vaccination. So for the parent, no, or the recipient, sometimes they will ask after getting vaccinated, do I need to take any meds or stop any meds that I am currently taking for vaccination? So we advise them to continue to take their medications for their condition unless there has been explicit advice of their doctor to discontinue these medications. So what do I do if I experience any symptoms after vaccination? So the primary call to action is that they still need to consult their doctor, primary care physician, for assessment. And they can be reached through their own personal numbers, no? Or through the vaccination site hotlines. These primary care physicians, these first responders will advise if it's necessary for them to go to the nearest healthcare facility or the vaccination site where they got the doses of the vaccine. And it is important to note that any of these adverse events following immunization will be investigated systematically by the right experts from our national and regional adverse events following immunization committees to determine any causal relationship to the vaccine. This was also mentioned in the chat, and I think it was also highlighted by Doc that what support can I expect from the government if I get hospitalized for AEFI? So at present, no, existing PhilHealth case rates may be used for your hospitalization as applicable. Um, but there are certain limitations of our funding for the serious AEFIs. Yes, PhilHealth administers the National Vaccine Indemnity Fund, but it may only be used after investigations of the experts are completed for serious AEFIs. So ang concern natin kung ang ating magulang at ang kanya anak na napapakunahan na sa ER, anong pwedeng sabihin, no, na tulong na maaasahan nila. So una po, existing PhilHealth case rates. And if our hospital sites are linked to the Malasak centers and the Medical Social Welfare Office, that can add to the initial support that they could get. Because the fund will be used after the investigations have been completed. And it would be important to note that the specific provisions to determine how one would fit for claims, one would be eligible for claims, would be our PhilHealth circulars. So that's the first part. This is the second part for our vaccination teams, how we can equip you during crisis. And this is our crisis communications issuance, our department memo 2021-0224. And these guides our LVOCs are implementing sites for AEFI related communications. So these are our principles. We need to be able to swiftly manage AEFI. And this swift management is critical to the effectiveness of the program. Um, Second, we need to stick to our holding lines. And third, we need to commit to provide accurate and conclusive info as soon as it is available. So we know that there is a process that has to be taken for investigation by our experts. But during that process, in between, we also still provide regular updates to our families who have been affected by these AEFIs. Fourth, we need to maintain an open and two-way communication with the public. And last, we need to express empathy at all times. So we need to build back the confidence in our vaccinations by having the science and the evidence free. And second, being empathetic and providing a feedback communications and being transparent with the processes. So for this initial run, initial phase implementation of the pediatric vaccination program, I'd like to direct you to the this third column, no? At the level of the DOHCO, this is the structure of our crisis communications team. At the central office level, our CCT or our crisis communications team, led by the Communications Management Unit, CMU, the Epidemiology Bureau, the FDA, and the World Health Organization, assisted by the HPD, manages and executes our crisis comms protocol as outlined by the issuance. And these include the development of our official statements, key messages, and other important collaterals and tools in close coordination with the National Adverse Events Following Immunization Committee or our NAFIC. So that's at the national level. Next is our regional level, the DOH Regional Office or our Center for Health Development, along with the Communication Management Unit and Health Promotion Unit. And also, they will coordinate with the RTF, Crisis Communications Cluster, or the Regional Task Force, Crisis Communications Cluster. Again, they also ensure that the protocols are followed in accordance with the issuance, and they can help develop the issuances and official statements, rather, aligned with the national CCT's statements and manage local media as necessary. So tayo po, as part of our vaccination teams, we fall under the third set, no, of the structure. And these include our LVOCs, Local Vaccine Operation Centers, implementing sites. And we also work not just with our hospital teams, we also work with our health education and promotion officers from the LGU, the public information officers, disaster risk reduction and management officers, and even our barangay representatives. And this is led by our LVOC along with the local task force crisis communications cluster. What do we do? They provide initial updates, initial findings, regular updates, and results of causality assessment. And then key here also is that we will be able, at the local level, we should be able to refer our families and recipients to both health and non-health support services. So what's the reporting process flow at the end of our communications? So first question is the AEFI local? First, number one, if it's not local, the international AEFI has to be verified, and then holding statements are already prepared, no, while verifying, and then disseminate the press release according to the verification and the necessary revisions to our holding statements. Later, I will show you what are our prescribed holding statements. A second scenario is if the AEFI is local, yes, so we're here, no, number two, and the vaccine recipient did not die. So number two. So is the AEFI serious or unexpected? If not, we just need to reiterate and provide our IEC materials to vaccine recipients. And then refer to hospital if the symptoms need further management. So this is for minor expected AEFIs. So the second arm for number two is the vaccine, the AEFI is local, the vaccine recipient did not die, and the AEFI is serious and unexpected. So what do we do? The LVOC, our implementing site, should reach out to the local vaccine operations center, who will then activate the regional substructures who manage the protocol. Our RAFIC, Regional Adverse Events Following Immunization Committee, and the Regional Epidemiology Surveillance. So Doc Gab showed the slide, no, the reporting mechanisms. So once this is triggered, the RESU will notify at the central level the Epidemiology Bureau, and the causality assessments will be conducted. So once that is triggered, we need to ask if the causality assessment is done. If it's not yet done, we issue our holding statements and the necessary updates, if any. If the assessment is already completed, there will be a press conference by our designated spokespersons to issue the information. The third arm for the reporting process flow if the vaccine recipient died. So if the vaccine recipient died, automatically the implementing sites will reach out to the local vaccine operations center, which who will then trigger the regional units to be notified and conduct the causality assessments. And again, if the assessment is already done, uh, press conference by designated spokesperson. If not, we issue our holding statement with available updates, if any. At the level of the community. So the first one is the reporting process flow, and then what we will issue. This second diagram shows what do we do at the level of the community. So first, we ask if the AEFI is not a local, no, number one. We wait for the National Communications Management Unit to issue the press release and disseminate this press release to our communities through their acknowledged community leaders. Second, if the AEFI is local and the vaccine recipient did not die. Okay, number two, local did not die, but the AEFI is not serious, so minor only. We reiterate the orientations at the vaccination sites on what are the expected minor AEFIs. If the AEFI is serious, the city or municipal health officer or the designated local vaccine operations center staff and local community leader will need to proactively reach out to the family uh, to apprise them with the initial clinical findings. If the causality assessment, is not yet done, we issue our whole prescribed holding statements and updates if available. If the causality assessment is already done, the same people will be the ones to reach out to the family about the results. That's the second. Number three, if the vaccine recipient died, automatically the city and municipal health officer, LVOC, and local community leader will reach the family of the deceased, and then we will need to tap, the LVOCs will tap local grief counselors and mental health and psychosocial support staff to provide the family of deceased other health and non-health support and coping strategies. If the assessment is already done, we inform them of the results, and then if not yet, we give our holding statements and available updates. So when do we release statements? So I already know when will I report and who I will report to. Number two, at the community level, I already know when to reach out to the family and who will reach out to those families. Now, what I need to know is when will we need to release the statements. So first, the first question that needs to be answered is the causality assessment done? Arm number one. If it's not yet done and there is no media inquiry, we wait for the causality assessment conclusion. If it's not yet done but there is already a media inquiry, we issue our holding lines. The second arm, the causality assessment is already done, but there is no media inquiry yet. We include in the monthly public briefing of the Food and Drug Administration on COVID-19 vaccine AEFs. But if there is already a media inquiry, the CHD will release a statement upon clearance from the CCT, which is led by our communications management unit at the national level. So what's important here is when we do get cases of AEFIs, and then we've determined the category if it's serious, not serious, we immediately reach out both to the regional office, Metro Manila CHD, so that we could get assistance from the regional task force, crisis communications cluster, and the health promotion unit and communication management unit of the region. Also, we need to reach out to the LGU, the LVOC crisis communications cluster also. So I mentioned a lot of the holding lines. There are, I think, 5 or 6 sets. I'll just briefly run through them. All these holding lines are also included in the same issuance that outlined the previous section of this module. So if there is a death during ongoing causality assessment, essentially our holding lines follow as this format. First one, give them the facts. The next, second, provide the action that's being done. And third, provide reassurance. So if there is a death during ongoing causality assessment, we provide them the info. So on a certain date and certain individuals in this location became severely ill, and it happened at this time. They received a COVID-19 vaccine immediately, and we express our sympathy to the family of the deceased. So those are the facts. And then second, the action done. At present, there is still no reason to believe that the illnesses and the outcomes were caused by the vaccine. However, our regional and national EFI committees have been activated and will investigate the incident. We will keep them informed as the investigation progresses. For reassurance, we emphasize that children around the world have received the vaccine, and at present, the evidence still continues to show that it remains safe and effective in giving protection against COVID-19. So that's for our first set, death during ongoing causality assessment. Second, serious AEFI, an occurrence of serious AEFI upon identification. So again, the same format. What are the facts? Unfortunately, we've noted that a person experienced severe reaction after getting vaccinated, and our professionals or medical teams are providing the proper care and management and monitoring of the person. If a condition update is available, we also provide that to the family. And then the action that's being done is the same. Our regional and national AEFI committees are investigating these. So while these severe allergic reactions and serious AEFIs are rare, they happen in people with history of severe allergies. So more information will be provided as the investigation progresses. Then lastly, again, we reiterate the assurance that the benefits of being vaccinated still outweigh the risk of these rare events. Third, if the serious AEFI has already resolved. So the facts are that the management of our medical professionals have helped successfully resolve this incident of severe AEFI. And while causality assessment has determined that this adverse reaction was shown to have correlation to the COVID-19 vaccine, these are still, our experts still continue to reiterate the rarity of severe AEFIs similar to this. And our patient or vaccine recipient has already fully recovered and gone back to their home in home. Then again, reassure them that the benefits still of getting vaccinated continue to outweigh the risks. For unresolved serious AEFIs, we will update them with this holding line. Our medical professionals have administered relevant interventions but have been unable to resolve the complications brought about by the adverse event. We're also in constant communication with the affected families and continue to provide them with relevant support. Second to the last, a minor or non-serious AEFI. Fortunately, some people still experience these unserious AEFIs, and these have been noted in other countries that also use the same vaccine and continue to use it. And we recognize that these are unpleasant. However, they are not very dangerous and will soon resolve for us. Our teams are equipped to handle and manage and reassure people who experience these symptoms. Emphasize again that reassurance of the benefits of getting vaccinated outweigh the temporary discomfort caused by these minor or non-serious AEF. And then lastly, for an international AEFI that has resulted to death or a serious AEFI, permanent disability, uh, provide the facts, the date it happened, where it happened in the country, um, what vaccine brand if available. And that the DOH and FDA are aware of this incident and are monitoring the results of their investigation on the causality between the vaccination and the reported AEFI. So at present, while these are not yet available, we emphasize, the DOH and FDA emphasize that there's no indication for us to stop the rollout of the vaccines. We are closely coordinating with our experts and regulatory bodies on this matter and assure the public that all deployed vaccines are being closely monitored. And last, the second half of that is we continue to reassure them of the benefits of the vaccine still outweigh. So what's important, we have constant communication. This is what we have. These are the facts. We let our science speak by showing them that our experts are investigating this. And while there are limits to what we know, we communicate what we do know. And once we have more information, we update in the files. That's my last slide. Thank you very much.
To advance the agenda, optimum childhood well-being, and joining national campaigns to promote health education and community-wide disease prevention. This pandemic did not provide a template for us to follow, nor a playbook where we can source the steps to successfully end it. It has plunged us to self-introspection, not only of what our future will be, but more importantly, whether there is indeed a future to look forward to. This pandemic has taught us many lessons, primordial of which is the need to be connected and belong to a community of living and caring human beings. As more scientific knowledge is unearthed about the COVID-19 pandemic, we are slowly gaining traction towards a solution to this life-changing experience. This pandemic has united us to believe in God and in ourselves and to trust in the goodness and greatness of scientists who a year ago did not have an idea how a vaccine against this virus can happen. Now that some concrete and real answers are available, let us be avenues of truthful discourse and champions of protecting each other through adherence to safety protocols and vaccination whenever possible. Today, there is a beacon of light, a silver lining where hope rests. The first wave of vaccination rollouts for adults have favorable impacted the quality and quantity of the COVID-19 landscape. Though far from ideal, we must celebrate the headways we have accomplished. As we roll out this second wave of vaccination for the pediatric age group, we are again provided another handle to hold in our ongoing journey to end this pandemic. The PPS celebrates this occasion to provide the young the opportunity to enjoy the benefit to be protected from sickness and death through the COVID-19 vaccination rollout for children aged 12 to 17 years old with documented comorbidities.